brings us to Chris. Off you go, and thank you for joining us.
Hi, good afternoon, everybody. Thank you for joining. My name's Chris Jordan. I'm one of the orthopaedic consultants at Imperial College Healthcare. So our main trauma site is St Mary's. So in northwest London, just north of Hyde Park. The centre's been involved in a number of major incidents, London Bridge, attack some while ago. More recently, there was a incident when a car hit a school in Wimbledon. We were stood up as a secondary centre, so we do have some experience, and we're obviously fairly prepared for it. I hope we are. Anyway, so one of my specialist areas of interest is pelvic and acetabular reconstruction. So I'm quite often involved in some of our more seriously injured patients, and often one of the users of the blood bank during my operations and before. Okay, so we go to the first slide, please. So major incidents, what should happen? So this is what should happen in major incidents. Everyone should be coordinated. Everyone should know their job. Everyone should move in synchronicity. Okay, and it was interesting this morning you did a word cloud on what does incident management mean, and some of the big ones were planning, communication, being prepared, good team building, clear communication, resource management. And I think that's, you know, some of those things are instilled here. So we're seeing everyone come together knowing what they're meant to do to get a result. In my experience, what actually happens is what we see on the next slide. Everyone just runs around. People get very excited. A lot of people who either don't know what they should be doing or do know what they should be doing, but actually just want to get involved. When I was a registrar, I was involved in a major incident at a hospital, and as a senior registrar in orthopedics, my role was to report with my cohort of other surgical registrars to our day surgery unit, so we could then be sent down as packs to A&E. And there were two people there. There was myself and another orthopedic registrar, and every single other person just descended on A&E in a scrum because they were desperately excited about what was happening. And it doesn't help. You end up just having a completely overclogged A&E. No one knows who anyone is. No one knows where the comms are, and it just is utter chaos. So what we've got to do is try and work against the chaos. So if we move along to the next slide. So I'm actually an engineer by background before I went into surgery. So the second law of thermodynamics, for those that don't know, is for a spontaneous process, the entropy of the universe increases. And you might say what entropy is. So if we just click forward one. This is the one of the dictionary definitions of entropy. Just click on, there we are. So degree of disorder or uncertainty in a system, or I like this one more, the degradation of matter and energy in the universe to an ultimate state of innate uniformity is the general trend of the universe towards death and disorder. Now, anyone who's seen a major incident or even a busy ED department will understand that the general trend towards death and disorder, if left unchecked, is where we will end up. If we click on, so our job is to impose order on that and resist the trend towards death and disorder. Okay, so when it happens, what we need to do is we need to be prepared enough, and it goes back to all those things you put in that word cloud: organized, communicate, manage resources, and the best way to do that is through a preparation. So I apologize if some of these slides cross over with what you've seen already, but I think they're worth reiterating if they have. We can go to the next slide, please. How do we impose order? So first of all, we make plans. Okay, so we have major incident plans, and they define the chain of command. Okay, so within those, we define the roles and the responsibilities, and we all have action cards. So this may have been something that's already come up. Sorry, I missed some of the lectures before lunch. I had a management and a clinical situation needed my attention, so I didn't actually get to join. So my institution has a 204-page major incident plan, and there are 74 different separate action cards. Okay, and they go from everyone from the gold commander in charge of the incident to the F1 doctors, to the mortuary staff, to the volunteers in the hospital, and right across to the chaplain. So there's almost a role for everyone, and all those roles are interlinked and pretty key. So I wonder if you know what your role encompasses at your hospital or your institution in a major incident, and you know, most importantly, who and where to report to in a major incident. Because at least if you can do that, you can start off in the right place and know who you're meant to talk to, or at least know who you're meant to be taking information from and acting upon. Because if you don't know that, everyone turns up in A&E and it's a complete bum fight, and it doesn't actually help anyone. And you spend most of your energy trying to sort out where your staff are, not actually how to treat your patients. If we can move on. So this is the action card. So I'm an orthopedic surgeon. So you'd be lucky to know that my slides are not very technical. So hopefully none of the IT issues will affect us. I'm more into hammers than I'm into information technology. So I report to the clinical commander in ED. And then I have defined roles and responsibilities. And every person has a card like this. There is a section on the bottom about what we do when we stand down for a major incident that I've left off, otherwise this becomes so small you almost can't read it. But it kind of gives me, as the on-call orthopedic consultant, a clear framework to work within, and then I will then disseminate to the rest of the orthopedic team how we are going to manage those patients in conjunction with everybody else. I think what you've got to remember, and hopefully is becoming abundantly obvious, is that medicine is a team sport, and even more so in a major incident. So we've got to think about who we need, where we need them, and what we're going to do with them. Okay, next slide, please. So what does it actually mean? So first of all, we've got to assemble the team. Click on. So we've got to assemble our team. Okay, then we need the resources. So we're going to tool up. Then we need to assess the problem. So in this case, it's the enemy. And then we need to go into action. Okay, so we need to think about who we need around us. So there are the wider teams. So within the ED department, there are trauma surgeons, there are anaesthetists, there are ODPs, there's the theatre coordinators, the ED doctors, there's the command, there's the ED nurses, there's radiographers. So I need to think about which team am I responsible with. So I report into a team, but I also have people who report into me. So I'll be looking at the other orthopedic consultants and registrars and fellows on site. So those who are effectively senior decision makers. We need to make sure what resources we need. So some of that might be in the emergency department. We might need to splinter or mobilize limb injuries. We might need to help with primary surveys. We might need to do assessments. And then, so that comes into the assessing the problem. And then we also need action. And it's not inconceivable that as part of that, I'll be myself or one of my team, as in terms of surgeons, so more broadly than just orthopedics, but surgeons will go into part of the assessment team. I was in an emergency department once as a registrar, and we ended up having 4 level 1 traumas all come in separately. So it wasn't one incident, but they arrived in pretty quick succession. And actually what happened was our trauma team, every time someone new came in, got divided down, and we actually ended up quartering the team so that each person had a a small trauma team around them. But we had to think about that, and what that required was for us to potentially step out of what I would call my core skills and do things like the primary survey on an ATLS, possibly getting bloods or putting lines in, which is not what I'd normally do, but something I might need to do. So it's all of those things. And the action can be everywhere from ED, because I don't do pre-hospital and the other surgeons would unlikely be, and then all the way through to theatre, and then obviously thinking about that aftercare. So if we can move on. So in terms of staffing, so our protocol at St Mary's is we have a trauma surgeon who's on call. So they will go down to a ED, and they have a set of skills that are generally general surgeons with some vascular abilities. So they will make calls about patients that will need some sort of surgical intervention. And often in a mass casualty situation, there are people with orthopedic type injuries, and they can be in a variety of sort of severity. So some might just need some minus treatment, some might need temporary stabilization, and there are others whose orthopedic injuries or limb injuries may be so severe that they are actually causing them to be at risk of life or limb injury. So we need to work together. So I need to think about which consultants and registrars are on site and potentially other trust sites. And then I need to think about calling people in. So this will all be part of the brief, what the incident is, how many casualties we're expecting, you know, when is it? Is it Sunday night? Is it 3 a.m. on a Wednesday morning, or is it actually 11 o'clock on a Tuesday morning and I've got quite a lot of people around? The other thing I'll do is I'll look to hold up theatre lists within the trust. So if patients are on table, we'll finish up those cases and hold so that we increase our capacity to take other patients through. So we have an emergency theatre that sits there for code red patients 24/7, but obviously in a major incident and we're looking at a mass casualty event, we may potentially have, you know, 5, 6, 7 theatres all running as emergencies. So I will liaise with my colleagues, and by standing those theatres up, I can then utilise those colleagues to come and help me. And what I'd do is look to create small isolated teams. So with an orthopaedic surgeon, general surgeon, that can go and take a patient, make an assessment and think about what needs doing and help prioritise them in terms of what order we get them up to theatre. So that's allocating our senior decision makers. They potentially need to cover minors, majors and resus. Obviously our main priority is going to be our patients in dire need of sort of orthopedic input or surgical input, so our P1s and 2s rather than our walking wounded. So we obviously have the trauma surgeon at St Mary's who will guide us on thoracic and abdominal injuries that would go to theatre as well. So it's all about that team sport, that coming together. And then we need to think about staffing for theatre. So we've got multiple theatres going simultaneously with multiple surgical teams. So we need to think about what surgeons we've got available and then everything else that makes surgery possible. So if we move on to the next slide, please. So we've got equipment, and I've broken this down into soft and hard. So soft, we need our surgeons, okay, with suitable expertise, and we're focused on the limb and life-threatening injuries. So we're likely to need general, vascular or trauma surgeons, and they'll usually lead. And then depending on other injuries, might require orthopedics, plastic surgery and neuro. But we don't function autonomously in theatre. We need all that support staff. So we need our scrub staff, we need anaesthetic support, we need porters, we need recovery staff. And that's just to name a few. It's obviously not an exhaustive list, but we need to make sure all of those resources are aware and stood up and on board so that we can then sort of implement our major incident. And so all those staff will have major incident cards, so they will know what to do, they will know where to report to, and then what's going to happen. And then the most important thing is to have a plan for each patient. So you need to be able to allocate staff to a patient to assess them and make a reasonable stab at sort of diagnosis and at least a plan of attack if they're going to theatre. Usually if they're going to theatre acutely, it's because they have life or limb threatening injuries. So what do we need to do to temporise those and take them out of that risk? The next slide, please. So then we get onto our hard. So we need cell salvage, we need level 1 infusers, we need to make sure we've got an adequate supply of blood. And Sadie may well have covered this because they look after all of this for us, and we're very lucky. They'll usually lead with input from surgical specialties, and we need to think about predicted and potential for further blood losses on top of what's already happened. So our major incident plan, we upregulate to 20 units of O positive, 20 units to O negative, and 8 units of FFP in both our AED department and theatres. And then, of course, any one potential patient's got the ability to trigger a major hemorrhage protocol as well. So that's increased from what we normally hold in theatres and ED on the basis of that. So I know that the blood transfusion and the haematology techs have all got an action card, and part of that is pulling in blood products from peripheral sites, other parts of the hospital to make sure they're available in ED and in theatres. In terms of equipment, things we've got to think about are, do we need to open a chest to stop bleeding? Do we need to perform an abdominal laparotomy to stop bleeding? Do we need to undertake a vascular repair or cross-clamp an aorta? And then potentially other causes of bleeding that might allow a patient to die if not rectified are long bone or pelvic fractures. So we need to think about what kit we've got in theatre to manage those. So there are trays for emergency laparotomies, there are trays for emergency chest cracking, and we have orthopedic trays to undertake external fixation to temporary stabilized bones, all available for exactly that reason. So I speak from very orthopedic leaning because that's what I do, but from an orthopedic point of view, we have 10 trays at St Mary's of orthopedic X-fixes that are sterile and ready to go, that are the similar that is issued to the military, that are just there in case we have a major incident. So one can be taken into theatre, everything is there, and we don't need to think about breaking into the kits we normally use. So it's much more straightforward. So it's all about simplifying that plan. What we need to do in that high chaos, high pressure event is make things straightforward. So our laparotomy trays all packed, our thoracotomy trays all packed, our X-fixes are all packed. They just come off the shelf, and our scrub nurses know where they are, know what to do with them, and they're pretty easy to access in terms of surgeons. So it's all about making things straightforward. But then we also need to think about other things. So obviously we need to think about patient warming, we need to think about tranexamic acid, we need to be aware of these other adjuncts that can help patients survive that are all related to bleeding and clotting and fluid resuscitation. So our trauma patients will typically go onto an air warming mattress, and we'll make sure we put bear huggers on them. And there's often this period where they get transferred into theatre, they get moved onto a operating table, and then we stand back and have our team brief and we go through what we're going to do. And sometimes you realize the patient sat there, maybe exposed, and actually there's an opportunity there to try and keep them warm, try and maintain their clotting function, or at least as best able. So that's really important, and I'll come on to a little bit of that in a second. Next slide, please. So triaging of patients. I know one of the first talks we had talked about a post-assessment triage. So I don't know if this has now been overtaken, but in terms of major incident triage tool, and now from what we were saying earlier, then there's now a grey wristband. But fundamentally, we're looking at our P1s and P2. So P1, immediate care required, and P2, immediate or urgent care. So we're talking 2 to 4 hours for our P2. So these are urgent patients who need something doing immediately. Now, usually P1, the initial commencement of their treatment would either happen pre-hospital or in ED. So we're thinking about chest drains, we're thinking about cardiac tamponade that's been decompressed, we're thinking about tourniquets on major hemorrhage, those sorts of things. But we then need to make those treatments somewhat more definitive. And then our P2s are those more sort of slightly less significant but still very urgent things. So our P3s are more like our walking wounded, and we can probably come to those later in the day or tomorrow, but we need to make sure that we can adequately deal with those. And often what will happen is we will look to shift some of those patients out to other units, and that may well happen before they've even come to hospital. So the ambulance services are extremely good at looking at casualty numbers, thinking about where they're going. They know the networks and they know where some of these patients can go, and they're experts at triage. So they actually do a lot of this for us. But we will also think about, we'll get some of these P3 walking woundeds maybe coming into our hospital. So they've walked away from scene and then they presented to the nearest hospital afterwards. So they may not have got diverted because they may have presented onto their own scene. So we need to think about that. So in terms of staffing, we need to be aware that we are going to have probably an increase numbers into the A&E on top of those P1, P2 patients. And we need to be able to manage those appropriately, because some of those may actually not be P3 patients and may need more urgent care, and it's about being able to identify them and manage them appropriately. Next slide, please. So transfer to theatre. Okay, so this is all the teamwork and what we do next. So we need to think about a coordinated transfer to theatre. There's no point just turning up to theatre with a patient and no one's expecting it, no one's ready. So the theatre coordinators are absolutely key. They keep an eye on which theatres we've got, what manpower we've got in theatres, what's going on. So they have a real bird's eye view of it. So it's imperative that they know where we are, who we're with, patient-wise, and what we're planning to do and where we're going. So which theatre, is it ready? Is the equipment available? Is it being checked? There's an ODP in theatre awaiting arrival. So an operating department practitioner. So is the anaesthetic machine set up? Is our rapid infusers set up? Is the warming on? Is, you know, are those sorts of things taken care of? So what you don't want to do is come and then suddenly be looking for kit, changing the bed we're on, all those sorts of things. So which lift are we going to use? Is it under porter control? Is it going to stop at every 4? Have we got the appropriate life support equipment to come along? And if we get stuck in the lift or something happens along that journey, have we got the things? So we'll take the transfer bags. But again, in a major incident, do we have enough of those? So it's thinking about all those things. Once they're in theatre, do those transfer bags need to go back down to A&E for the next patient coming up? And it's all these little things that sometimes get overlooked. And then it's really important that just because we're in the unusual, we don't forget the usual. So consent forms for patients, doing a team brief, checking the kit we've got, doing a sign out. So we've got the right patient. Have we thought about antibiotics? Have we thought about warming? That should say positioning. I do apologise, there's typo from my part. So positioning the patient on the table. Do we know what position we want to be in? And does that work for all the specialties? And if not, do we need to change position partway through the procedure? So vascular have done something, and then orthopedics will do something, or general surgeons will do something. Do we need to move around? And how do we best manage that? And there is always some give and take in that, but that's all comes down to communication and having those key people all in the room, and ideally senior decision makers who know what we're trying to achieve. So we're not talking about SHOs, as good as they are. We're talking about people who've done the procedure, are comfortable with it, and know about the pitfalls, so they can preempt kind of what may or may not be needed. Okay, so everyone will be amped up. So just remember process. So in theatre, so we're thinking about breathing and airway issues. Now these are potentially P1 type injuries. So they're usually dealt with pre-hospital already. So they've already had their ET tube, they've got an airway in, they've had a tracheostomy, they've had chest drains. Okay, so we're thinking probably more along the lines of circulation. So we need to stop bleeding and replace losses. So where are these losses coming from? Into the chest, into the abdomen, visceral injuries. So junctional hemorrhage, I don't know if that's been talked about. So these are injuries at the axilla and at the groin, where major vessels are pretty close to the skin, but very hard to compress. So you can't put tourniquets on a very high sort of shoulder wound or a very high leg wound where it's in the groin or the axilla. So how you manage that and how you get control. So it's having an idea of that. And then peripheral injuries, you know, if you've got a peripheral wound or number of wounds that are oozing, eventually you'll lose enough blood that you will expire. So how we manage those. So we need to stop, we need to replace the losses. So temporarily we can use tourniquets, pressure dressings and transfusion. And then definitively, so thoracotomy, laparotomy, aortic cross clamp, vascular control, and then to some degree vascular stability, fracture stability, not vascular stability, fracture stability. So I'm thinking there more like long bones, the femur, and potentially the pelvis. That's for sort of major life-threatening hemorrhage. So we need to decide between what we call damage control surgery and early appropriate care. There's a number of things that are going to affect this. In a major incident with multiple casualties, we are likely looking to do damage control surgery. We're looking to stabilize that patient, to get them to a safe level where we can come back to them, but they're not at acute risk of expiring or having, you know, long-term limb injury if we can avoid it, versus early appropriate care. So that's where we try and undertake sort of definitive procedures if the patients allow it. So one of the big things is patient physiology. Does it allow us to actually do more invasive, more prolonged interventions? The problem with that is that takes longer in theatre, it takes resources, and if we have multiple patients needing to come through, that's often not appropriate. So the number of patients needing surgery, those resources, so time, theatre, blood, equipment, so surgical equipment and implants, but also expertise. Have we got enough surgeons that we can do that? The likelihood is in this type of event, probably not. We're looking to just make everyone safe, take a breath, and come back to it all. Next slide, please. So physiology is a big one. So we need close liaison between the anaesthetic and surgical teams, okay? So surgical teams usually create blood loss and then hopefully stop it, and the anaesthetists battle them the whole way through. Hopefully it's a fairly cohesive relationship, okay, but we rely on the anaesthetist to keep these patients alive while we muck about and do our stuff. So it's really important with blood loss, we think about already. So what's already lost, what's already been replaced, what is currently going on, and then what is predicted. So they may have had transfusions, they may have had products. Currently, they might not be bleeding, but that might be because they've got a tourniquet on, or they've had their aorta cross clamped, or they've had a Reboa put into their aorta. So what's going to happen when we take that tourniquet off, when we let the Reboa down? So not just in terms of blood products, but about products of anaerobic respiration that then flow from the limb into the body. So we need to think about all of that. We need to think, when we take this tourniquet off and we're trying to get control, we're going to lose more blood. Do we need to preempt that? And that's all a discussion, and it should be very proactive and not reactive. And that's very much the surgical teams need to be talking to the anaesthetist, saying, this is what I've done, this is what I'm going to do, this is what I'm expecting. And the anaesthetists equally need to be like, a bit like, what's going on, what are you doing next, how's it going, what are you expecting? And if you have two integrated teams that are both quite forthcoming, it can be a really great relationship and really harmonious. And that's really important. So it all comes down to that communication. So we're thinking about volume replacement and clotting. So the ROTEM, so the rotational thromboelasto, I can't remember the last bit. You can tell I don't do this. We're thinking about blood gases and monitoring. So how much and what parts of blood have they had and do they need? So I'm aware that this goes on. I've never looked at one in anger. So you're not, what you want me to do is just do what the anaesthetist says, is probably the best option here. Going back to the previous slide, if we are looking for early appropriate care, in terms of their physiology, we're looking to keep their lactate below 4. Also, oh yeah, no, that's right. Go back to the slide. That's it. So we're looking to get their lactate below 4. But the big thing here is the trend. If the trend is downgoing, that's positive. So that's adequate fluid resuscitation with appropriate fluid. So usually blood or other blood products, as well as possibly some crystalloid. But we tend to avoid that unless there's a reason. So again, the anaesthetist will be managing that. But it's the trend. What's their pH doing? What's their base excess? So really, we're looking at what their physiology is doing. Are they going off, or are they maintaining sort of relatively normal levels of physiology? So if you have a major incident and actually only one or two, so it's a minibus, but actually only one or two come to theatre and most people are walking wounded, it may be you're looking at appropriate care, early appropriate care. But we need to be careful. Is the patient physiologically able to tolerate what we think we should do or want to do? Otherwise, we opt for damage control surgery. And there are a number of criteria that we look for that, and they can be related to injury severity score, age, hemodynamic stability, biochemical markers. There's a whole host of things, but fundamentally, if they are physiologically able, we can keep going, but we need to be very careful. So it's constant monitoring, it's constant blood gases, it's constant sampling. It's looking at our physiological trends on the anaesthetic monitors. It's talking to our anaesthetist. And I mean, when I say looking, it's the anaesthetist looking at that and feeding back to us. But, you know, I will always look up, I'll have a look, what's the heart rate, what's their temperature, what's their blood pressure on their arterial line on the anaesthetic screen. As much as I trust my anaesthetist, I'll always have a look for myself. Just I want to know as well about what we can do and how much we should do. Of course, you need to think about other things outside of theatre, so other patients, etc. We move on. So then we need to think about support, because we all get excited, we all think about A&E, we all think about these fun patients coming in and helicopters landing and people running around in jumpsuits and there's blood on the floor and everyone's excited and things look cool. But actually, there's a lot we need to do elsewhere. So we need to clear space on the wards to allow this influx of patients. So we need to think about our discharges and repatriation to patients to their local hospitals. So as a major trauma centre, we have a lot of patients who come in from the region who are waiting to go back there. Now, in a major incident, they need to go back there ASAP, because these patients need to come through A&E, go to theatre, go to recovery and come to a ward, and we need space for that. So there's a really important sort of back office portion of this, getting those patients back, getting people home as soon as we can. And that's just as important as running around downstairs feeling like you're part of ER. Okay, so if you are involved in a major incident and your role does fall to more of that support and less away from the glamorous thing. Don't think it's anything any less important. In fact, it's potentially even more important to keep the whole hospital flowing. Because if we grind to a halt, it doesn't matter what comes in through the front door. If we've got nowhere to put it, we can't do anything for them. Then we need to think about our plan to return to theatre. So we need to think about timing, specialties, and definitive care. What is a big thing with these trauma patients is they come in, they have initial stabilizing surgery, usually with their trauma names, and then maybe a day or two later they're going back for more definitive surgery. Their physiology is okay, and they're all good to go. And then they get a wristband in their own name and their own date of birth. And what's really important is we keep those both wristbands on, because they may well have had blood cross-matched in their trauma name. And if someone's removed that trauma bracelet and they've now got their own given name bracelet on, we then can't give them that blood. And we get into this, do we recross-match them under their new name? And it all creates delays and problems. So it's really important that there is a time period when we identify who they are and allocate that to them, that they wear both wristbands so that we can give them cross-match blood depending on which name it's under. And then we'll aim to transition them to their own given names and merge all the records at a point in time where things are relatively stable. So up-to-date bloods for the patient. So they come in, they've had their big trauma, they've had their transfusions and their initial operations. So what are they doing? What's their clotting? What's their HB? What's their hematocrit? What's their renal function doing? What do we need to do for our next step? What do we need to address? And then we also need to continue caring for our pre-existing patients and our new admissions. So we need to think about that in conjunction, because this is all a new burden of work on top of what we normally expect. So it's thinking about all those things. Next slide, please. And in the aftermath, so what do we need to do? Well, first of all, we should reflect. So what did we do well? Because there will be things that went well. What could we do better? So it's reflecting on that. What processes worked? What processes could be improved? What didn't work? How did our systems work? How do we improve? And then it's really important to debrief. So are the staff okay? So the focus is very heavily on the patients, but are we coping? So you look around to your colleagues, to your juniors, to your seniors, and check that people are okay and ask. And that's across the board. It might be that it's the porter who brought blood into resus, who normally delivers food to the orthogeriatric ward, who suddenly delivered, a whole load of blood and walked into a resus department where there's blood on the floor and someone's had their chest cracked and they've never seen that before. So it's not just clinicians, not just frontline staff, it's everyone who's been involved in that. So that's really important as an institution or as a organization that we look after that, because if we can't look after ourselves, we can't look after our patients. Next slide. I think that might be it. So there we are. So my take homes. Major incidents want to become chaos. Okay, so our job is to stop them becoming chaos. We're going to impose order. Everyone has their role and responsibility. If you do your part, you will hold back the chaos. So if everyone does it, we'll succeed. Only as a team do we succeed. Make sure you know your role, and hopefully you know your major incident plan. Thank you. Are there any questions?
I think people are posting questions within the chat and the QA sessions. I don't think I've seen anything come up for you yet.
Okay. I've seen
am I right in
pop
thinking
one up.
Yes, indeed.
So his 10-second triage and the grey wristband is at scene of injury. So that's why I don't know, because I don't go outside the hospital.
Yeah. So Alistair's done those before he's gone, but I think if I can invite people to put some Q's and A's up for Chris. I think, Chris, you've spent time in Australia, and I think
yes.
you've done your surgical leadership in Harvard.
Yes.
So you have the benefit of that international element. And I think just very briefly, whilst we're waiting for Julie to be loaded, do you want to maybe comment on being able to contrast and compare within other systems?
So in Australia, so I spent a year in Australia in one of Melbourne's 2 major trauma centres. Luckily, we didn't have a mass casualty event while I was there. The system is very, very similar to the UK. The only thing I would say is probably less people on the floor on any given day in terms of the specialties I was involved with. So A&E is very well staffed, but in terms of orthopedics, probably less people. It's a slightly smaller department. So just in terms of being able to call those people in, just because a large proportion of their health service is private, so the clinicians split their time between public and private. So I think probably if it happened, you're looking more at calling people in from external than having them on site at the time. Otherwise, very similar. So their processes are very recognisable to anyone who's worked in the NHS into the development.
I think what I'll do is I'll comment on that and then we'll hand over to Julie. But I think the fact, your very good point there about smaller team, smaller setup, that's actually very pertinent to a lot of the people on this call who don't work in major trauma centres. They're working within the network and they too need to have an overview of this and to know their role.